Hi there, and welcome to the Empowered Nutrition Podcast. I'm really thrilled today to welcome our guest, Jennifer Masters, who's a fellow integrative and functional dietitian. Welcome to the show, Jennifer.
Hi, Erin. Thank you so much for having me today. I'm excited to talk about our case study.
I'm super excited too. You're honestly a hero to me. I'm in a clinical doctorate program, and we write a lot of manuscripts, but then it's kind of like on you to ever try to publish it, and I never have the time. So I'm like, oh, she actually published one. I need to do it. I'm inspired. I'm super
Thank
impressed.
you.
I can't wait to talk about it. But hey, first, just maybe introduce yourself a little bit to the audience. Maybe share a little bit about what got you interested in functional nutrition and especially in the GI specialty.
Sure. Well, um, I first started my career fresh out of my internship at Emory at a children's hospital here in Knoxville. And actually, I was the first full-time clinical dietitian there.
Wow.
So I'd been there about a year, and then the first pediatric gastroenterologist in our city came to the hospital. So that's where I met Dr. Strobel, and he is a co-author on this study that we're going to talk about.
Mm-hmm.
And so that's where I got to know him, and he did transition into a private practice. And so I worked with him over a number of years, 30 altogether. There was a little break in between there. I moved to another state, but came back. But anyway, while I was working in the GI practice, of course, we saw a lot of kids, adolescents with irritable bowel syndrome.
Yeah.
And I was really, struggling, how can I really help them? And so I started hearing about one of the therapies that we did use in the case study, looking at food sensitivities using the mediator release test, or the MRT as it's known. And so that kind of launched me into this integrative and functional space. And I joined DIFM at that time. And just, it's been a journey, right? Just can never learn enough. And I've been fortunate enough to be in some courses that you've offered. And I just continue to learn more and more. But it was in this functional space of trying to, get at the root cause of a client's condition. How can we really help them instead of just trying to manage symptoms? And it's, sometimes we can even do that with diet, right?
Yeah.
So that's kind of where I got to be where I am.
Yeah, that's super interesting. I think with GI, there's an appreciation of dietitians, but I think a lot of times the mindset is sort of, so you can teach them the low FODMAP diet, but there's obvious limitations with that, especially when it comes to kids.
Right. And, it's not good long term, and it just manages symptoms, as you know. Not that there's not a place for that, but that's ultimately not where we want them to end up.
Yeah, because it's not treating and addressing the root cause. And so I think you and I, similar thinking of like, hey, let me get more into the world of functional medicine and integrative and functional nutrition so I can learn more about what's the root cause of these digestive symptoms and what can I do about that so that they don't have to be on the low FODMAP diet.
Exactly. And there is a point, so remind me if I don't get back to it, but we can think about this pediatric Crohn's patient and what could have been the root cause of him developing the disease in the first place.
Okay. Oh, that's like a little tease. Yeah,
Yes.
We'll have to come back to that for sure. Well, I know you said that you've done a lot of research on, a lot about the research with respect to nutrition and pediatric Crohn's disease. Do you want to share a little bit more about that?
Yes. I actually think that would help kind of set up our case study. And so back in, I want to say the late 80s, early 90s, there were some emergence of studies in the pediatric Crohn's disease literature showing the role of enteral nutrition therapy in actually putting patients into remission. Okay, so what was determined or found out that enteral nutrition therapy using, a formula exclusively for nutrition support, so you're not eating any food, getting 100% of your calories, that it was very effective in putting patients into remission.
Yeah.
So, you can think back to that time. Mainly steroids were used in pediatrics at that time to induce clinical remission. And, that's great, but there's some side effects that are worrisome, especially in a growing child. So it didn't have really good clinical outcomes in terms of growth always. So what the studies were showing that the nutrition therapies was even more effective than steroids in actually demonstrating mucosal healing. So now we're looking at biopsies. This became a standard of care in Europe. Here in the US, there are pediatric centers that still use this to some degree, but there's a problem with it if you think about it. And the problem is remission is not maintained once a normal diet is resumed. So, who is going to want to maintain a exclusive enteral nutrition therapy diet?
Right. Especially, yes. Almost especially a child, but really anyone.
Yeah.
Yeah.
And the other comment I would make, in these studies, it didn't really matter what type of formula was used. It could be, polymeric, it could be partially hydrolyzed, or it could be elemental. They were all effective. So, then you start to think about why do they work? Okay, what?
Yeah.
And so we'll follow that thought process here in a minute. But so because we didn't want to maintain patients on these diets forever, there were, later studies showed that, well, why not let's give 80 to 90% of calorie needs through a nocturnal NG feeding, and then during the day, get the rest of their calories for whatever they would like. So that was studied and found to be helpful to some degree. And then there were cycling, do an exclusive enteral diet for 8 to 12 weeks, induce remission. And then you would repeat a 4-week cycle every 3 to 4 months.
Yeah.
Again, you're coming out of remission, trying to put back and forth,
yeah,
so to speak. So the last study that I want to mention, which is very significant, and it kind of brings us up to the current time. This was published in 2017. And it was called the PLEASE study, a pediatric longitudinal study of semi-elemental diet and stool microbiome. Dr. Lee Baldessano, those of you in pediatrics may recognize his name. He's a researcher at Children's Hospital of Philadelphia. So he was part of this study. And there were about 90 patients in the study. And so instead of comparing the enteral therapy to steroids, now they're comparing it to the biologic drugs. So these children were either on Remicade, and I think maybe a few were also were instead on Humira. Okay. And so they had 2 basic outcomes that they were looking at. They had a pediatric disease, Crohn's disease activity index, and that's basically a survey. It's based on clinical history, lab work, a patient's report of symptoms. And then the other major outcome was looking at stool calprotectin. And that is a marker specifically for intestinal inflammation, and at least in pediatric Crohn's disease, it's highly correlated with endoscopic findings. And so it's a useful marker, a surrogate marker, if you will, for mucosal healing. Okay. And so they measured at baseline, 1 week, 4 weeks, and 8 weeks out. And there were really 3 groups. So they had the biologic group on drug therapy, and then they had 2 enteral nutrition groups. One was considered exclusive enteral nutrition therapy. They got 90% of their diets, calories from formula. The 10% was probably from just strictly, mostly clear liquids. So they considered that exclusive diet. And then there was a partial group. So the partial group only had just a little bit, about 50-50, a little bit less than 50% of their diet was from table food, and 50% or so, a little bit more from the formula. So what they found is that the exclusive enteral nutrition and the biologic drugs were almost dead even, no significant difference. They had in 8 weeks, they had a 65-66% reduction in their calprotectin levels, and very similarly, their disease activity index improved. Not so the partial group had about a 38%. So anyway, the bottom line of this study, and I want to point out some very important conclusions they make that really lead into the case study that we're going to do. But this appears that, like the steroids, it did not help with mucosal healing, that the biologics were the first drugs to actually induce remission and promote mucosal healing. So 3 conclusions that came out of this study is that the efficacy of the enteral nutrition was likely due to exclusion of harmful factors in table food.
Oh, so they actually called that out.
Yes.
Okay.
Rather than the therapeutic delivery of nutrients itself. Okay.
Interesting.
And if you think about it, if you're using a formula, you're eliminating what, 99% of potential food antigens?
Was it a fully elemental? Like, was it?
Well, no, but even if you,
it was like hydrolyzed.
You know what? I will have to go back and look at the police study.
But basically, you have the proteins are really broken down into very simple components so that they don't.
Yeah, so
they're less likely to stimulate an immune reaction. Yeah.
Right. So, you've got a protein source, you've got a fat source, and a carbohydrate source. So if you were to break that down into, okay, what foods are actually in here? So we're not even talking about the micronutrients foods. You just got a handful, right? And you're eliminating. So this is a broad-based exclusion diet. Wouldn't you agree?
Yeah, it's like the extreme end of an elimination diet. You've eliminated all potential like protein antigens.
Bingo.
Yeah.
Yeah. And so the second conclusion was that immunosuppressant with a biologic drug is able to overcome the effect of dietary exposure because they were actually eating table food.
That's it's still achieved remission, but by a different mechanism. Instead of where the formula, they're thinking it doesn't stimulate the immune system. But then with the biologics, they're saying, well, yeah, the food is still stimulating the immune system, but the biologic is shutting down the immune response.
Yes. Tumor necrosis factor. So it's blocking that, suppressing the immune system.
So like these inflammatory cytokines that the immune system makes in response to the stimulus.
Yes. So listen to the third conclusion. If the mechanism of action of dietary-based therapies were understood, it might be possible to develop less restrictive diets that deliver the same therapeutic benefit.
Cool.
Yeah. So this really transitions into using food sensitivity testing to determine, okay, for a specific individual, what foods are causing inflammation. All right. Are we ready to get into our case study?
Yeah, I think that's well, real quickly. That by yes, I mean no. One thing I thought you said that was interesting was that they concluded that like, okay, if you had some way to tailor the diet or like understand the right diet for somebody, you could have a less restrictive diet, and that's like kind of easy. The thing that's important to hear in that, I think, is that if you're utilizing a good food sensitivity test the right way, there is the potential for that. Whereas like the other, like I feel like a common like argument that I hear against food sensitivity testing is that it's going to like unnecessarily restrict the diet, so make it more restrictive than it needs to be. But they're saying there's potential for it to be less restrictive than it needs to be. So tell me what you think about that.
Well, I think the proof is going to be in this case study. So this young man was less than the third percentile BMI. And okay, when he first came to us, and I'll take you through the time frame of everything. So, that would even raise more red flags of potentially restricting the diet and what impact that's going to have on his growth, right?
Right. Someone
But
would be
we
like, "You're going
actually
to give him a food sensitivity test? You're crazy. He's already underweight." Yeah.
Yeah,
But go
so
ahead.
we actually saw the opposite happen with his growth. So that's one of the real I shouldn't be telling this ahead of time, but,
Don't give it away.
so,
Well, maybe just go through the case for me and just maybe like be a living abstract. Give me the background and go through what you did.
yeah. So, he was almost 13, 12-year-old, though, with chronic diarrhea, intermittent fever, abdominal pain. So, some obvious warning alarm symptoms in the GI world that needed to be investigated. He also had a history of long-term eczema. Um, his weight was at the 25th percentile, and he was at the 90th for his height. So his body mass index was less than the third percentile, as I
Yeah.
mentioned. So he did have an EGD and colonoscopy, and the initial diagnosis was Crohn's, ileocolitis, and gastritis. So initially, he was put on omeprazole and Pentasa. And so Pentasa is a 5-ASA, 5-aminosalicylic acid medication commonly used in Crohn's. Just to note, he had a poor oral intake. I did work with him initially to just, use a partially hydrolyzed Peptamen Junior, I think is what we recommended, trying to work on his weight gain. Gave him a general anti-inflammatory diet, tried to balance things out. He didn't really have that great of a diet. Ate a lot of sweets. And we put him on a multivitamin mineral. So he did well initially. And I did have some other interaction along the way. We won't go into details about that, but that lasted for about 9 months. And there was some visible red blood showing up in his stools. So there was another EGD colonoscopy, and basically revealed that the ileitis was definitely there. He also had colitis, and it was unresponsive to the Pentasa now. So Rawasa, a similar drug in the enema form, was started. And the plan at that visit too was to start a new medication. So this would be a 6-MP immunosuppressant. So if you think about, there's kind of a step-up therapy in terms of medications used in pediatric Crohn's. The baseline might be, could be steroids. It could be the 5-ASA. So the next level up would be the 6-MP drugs. And then the next level up for that would be the biologic. So we weren't even at the point of needing to put him on a biologic, but the plan was to start a 6-MP. So that's what they left the office with. And the mother was back in the office a week later. I think she'd been on the internet looking at potential side effects of 6MP. So, there are some rare side effects. It's been safely used in pediatric Crohn's for many years, but ultimately she was wanting to utilize some medical nutrition therapy alternatives. So fortunately, Dr. Strobel agreed for this. I had been using food sensitivity testing, the MRT test, for about 7 years now, and I had seen it, tracking outcomes over time. We used it primarily in IBS patients, but some even in migraine, fibromyalgia, over those years. And I saw great outcomes. So here I am thinking about, okay, why do these enteral nutrition formulas work? What was this PLEASE study telling us? Why couldn't we use this to see if it would get him in remission or, transition him to a more normal diet? Okay. Even if you use a formula to get somebody in remission, why couldn't this therapy even be used to, okay, once you go on a whole food-based diet, these foods are going to be safe. They're not going to cause inflammation.
Right.
Yeah. So there was another component that I suspected when I talked to the mother and the patient. I had a suspicion of dysbiosis.
Yeah.
He had a history of athlete's foot, fatigue. Okay, fatigue, you would expect that perhaps certainly in Crohn's disease as well. But when you're talking about potential yeast overgrowth, I almost always see that as part of the clinical picture, a significant part of the clinical picture. Crave sweets. And then I had him do a child yeast questionnaire score. And it was 190 with, a high score being 140 or greater.
Yeah.
Okay. So in my mind, I'm thinking, okay, do we need to do an anti-yeast protocol? Do we need to address food sensitivities? And so actually, I didn't know how much time I had. So we just did everything we knew to do with this patient, right?
Yeah.
And it's also important to point out, he had eczema, as I mentioned, irritability, some headaches. Three months prior to his diagnosis, he had onset of symptoms that was precipitated by a round of antibiotics that he had to have. Okay, so this again is tying into potential yeast overgrowth.
Yeah.
And so before we go further, I just want to point out later, several years later, looking in the literature, I found a review article that was very interesting. It was Fungal Alterations in Inflammatory Bowel Disease, 2016. And it was suggesting that alterations in gut fungi might be associated with the pathogenesis of inflammatory bowel disease. So here we go, a potential root cause.
Yeah. There's also a lot of research associating antibiotic exposure with pediatric IBD for sure. So
yeah. So they concluded in their review paper that modulation of the fungal microbiota might be considered as an actual therapeutic approach in IBD. Okay, so let's so maybe before we go further into the study, we want to back up. Do you think our listeners might want to know more about the MRT test or what it measures?
Yeah, I mean, just to tie up the ends here, did you end up doing MRT and an antifungal protocol, or did you start with just the MRT, or how did that go?
We started with both. And so I'm getting ready to kind of outline, what we did, what were the markers we measured before we started, and the outcome measures we were looking at.
Okay, then let's go into MRT, the test, and if you want to go into what LEAP is, that'd be great too.
Yeah. So MRT is just an acronym for mediator release test. It is a blood test that is looking for reactions to potential food antigens. And LEAP is actually an acronym for that, stands for lifestyle, eating, and performance. And it's actually the diet that is tailored to a specific patient's MRT results
Yeah.
that they follow.
Mhm.
So the MRT is kind of an endpoint test. It's not an IgG test, but it's going to capture all type 3 and type 4 immune mediated reactions. So IgE allergy would be a type 1 reaction.
Mhm.
Those are immediate. Type 3 and 4 are delayed. They're also dose dependent. So the fact that they're dose dependent and delayed makes it very difficult without some testing for anyone to be able to figure out, okay, what is my food puzzle going on? What are these foods causing
Yeah.
inflammation?
Yes. Okay. So, correct me if I'm wrong on any of the science, but what's happening with, like, let's say you get scammed on Instagram into buying some type of IgG food sensitivity test. You're gonna send in your blood, and they're gonna look for these antibodies that are probably just IgG, or maybe if it's fancy, you'll also get IgA. And then there's a lot of different companies that do that, and they'll kind of like promote different methodologies. It's like, hey, we're better because we use like the cooked versions of things versus the uncooked versions of things, and like things like that. But what the MRT is it's not looking at any antibodies at all, because the whole
Right.
controversy around antibody testing is that's not a reaction, that's just a potential for reaction. And we've actually seen, there's research where basically if someone has an allergy to something like peanuts and they get immune therapy for that allergy and they become where they're no longer allergic to peanuts, they'll actually have higher IgG antibodies to peanuts. So it certainly isn't true that, like, oh, you have higher IgG, you're going to be more reactive to that food. And instead, the way I understand it is the IgG is more the memory of your immune system, but just in the way that you may remember your best friend. That doesn't mean you want to attack your best friend. I mean, maybe you want
Exactly.
to, but like you probably remembering is different than always attacking. And so with the MRT, the difference of the MRT is it's going to take the cells, put them in the suspension, in the little tube, in the tub. It's going to expose the cells to the antigen, so the proteins from, say, pineapple or peanuts, and then and then what's going to be measured is the change in size of those cells as compared to controls. Because when cells react to something, they're throwing off these cytokines that are literally volume-containing molecules that will significantly shrink the cells if you take the average of the tube overall. And so that what their MRT is reporting is like the change in volume of the cells after the protein exposure as compared to the control tub of cells that were not exposed to the protein. Is that right?
Exactly. I couldn't have said it more beautifully myself.
I've had a little practice.
Yes. And, you know, the IgG testing too can just reflect that you've had exposure. Okay. So
Yeah.
just to tail in on the other things that you mentioned.
Yeah. So what I think is important about what you've done is you've shown, because I mean, let's just be honest. Let's talk about the elephant in the room a little bit. The MRT test has been highly controversial among dietitians as a whole, and the main argument that you always see come up is that it doesn't have any peer-reviewed evidence to support it. And so that's the main reason why I thought it was so important for us to have this conversation, because I think it's important for anybody that believes in the efficacy of the MRT test to get a paper out there and publish it, so that becomes less of an argument, if that makes sense. I know we're diverging a little bit, but
Yes. Yes.
that's basically what you did with him, is you gave him this food sensitivity test that measures those mediators. And then maybe you could talk a little bit too about the LEAP diet itself, because talking about, say, like I go to CVS and I get this IgG test off the shelf. I get a report and it tells me to cut all these foods out, and then I go somewhere and I start telling people I'm allergic to celery or I'm allergic to peanuts and I never eat them again. Tell me how that's different than like the LEAP diet.
Well, it's very different. First of all, I see a lot of patients in my practice that have had other tests and they come in and their food list gets a lot smaller over time because they haven't reintroduced anything or had any guidance, first of all, on how to utilize those tests.
Mm-hmm.
Okay. It's basically you get a report, here it is, see you later.
Yeah.
And the dietitians and practitioners that use the MRT test have had training. And our overall goal is this is not a forever diet. It is for a period of time, a therapeutic diet to decrease inflammation. And our goal is for always be able to reintroduce foods because patients can regain oral tolerance over time, especially if you're working to correct the root cause. Okay.
Yeah.
So in this case, yeast overgrowth could be the root cause of the food sensitivities for sure, but even of the inflammatory bowel disease itself.
Yeah. Yeah, we think alike in that. If I'm finding that someone has a loss of oral tolerance, I'm always like, okay, we need to work on, it's often dysbiosis is a major player of that. And if we work on that, that's going to improve your likelihood that you can successfully reintroduce foods. And it's like a high priority to be able to reintroduce and bring those foods back and not just have them out forever. I think as people know about allergies, that's how they get this thinking of like, they think that they get a food sensitivity test, that food's just out of their life indefinitely because they think about it the way that they know about, hey, in the movies, somebody's allergic to shellfish. It's like never again, but it's very
right.
different.
Very different. So the process is very different. Anything else before we launch into the therapy we used here?
Yeah. Tell me about the therapy. And then if you talk about the LEAP diet at some point, maybe talk about like the specific way you applied that, if that makes sense.
I will, because in this case, we're doing more than one intervention.
Yeah.
And so I did alter it a bit.
Okay.
You'll hear about that in just a moment.
Let's do it.
So we did the MRT blood draw and got the results back. Patient came into the office. And so it was all timed. The major outcome that we were going to use to measure was going to be the calprotectin level. Okay. So the calprotectin measure was measured, and then they started the MRT plan along with these others that I'm getting ready to tell you. I did put him on our curcumin and boswellia supplement. You may be familiar with Curcumax Pro. It's integrative therapeutics tablet twice a day. But we also did an anti-yeast protocol. And I used antifungals. I used the MRT test to inform me about what antifungals to use. To be honest with you, I typically use a combination product.
Yeah.
But there was something I can't remember in the product I usually use that didn't match up with his MRT results.
Okay.
I mean, it could have had oregano in it or something. I'm not sure.
Sure.
So for the antifungal, on a rotating basis, weekly basis, he would switch from caprylic acid to garlic to grapefruit seed extract.
Okay.
Also had him on, at the time, it was VSL number 3.
Oh, okay.
Visbiome.
Yeah.
As we know it today, and Saccharomyces boulardii.
Okay.
Now, when I take kids through an anti-yeast protocol, I don't really restrict their carbohydrate, except this is the one rule: no added sugar.
Sure. So they could have like an apple, but not a candy bar.
Right. So basically, we did avoidance of his MRT reactive foods, no added sweets, the antifungal protocol, the supplements. So it's a little bit different than I would normally use MRT protocol, according to the phases, starting with the safest foods and building up. We just did avoidance.
So did you take out, because like on MRT, for people that haven't seen it, there's basically like 3 different colors. There's like a green food, which are the safest foods. And then there's like the yellow, orange, and then there's the red. So did you take out the red and the
Absolutely both, reds and yellows.
Yellow.
Yeah.
So you took both, all of them out fully, or is it just like minimizing those foods?
No, they were cut out completely.
Fully. Okay.
Yeah. So, the mom did all the safe foods, as you know, are on a phase 1 through 5 plan. So that served as the basis of his foods. And mom was great. She came up with the most amazing recipe combinations.
Go her.
Yeah, she did a great job with it.
So you actually had them follow the phases then? You didn't have
No,
them,
no.
You just had to do within the greens. Okay.
Yeah. Just focus on these foods,
Got it. Okay.
But really all we did were avoiding the reds and the yellows.
Okay.
And taking out added sugar from the MRT.
Got it. Okay.
Yeah.
And how long did you have them do that? Do you remember?
Absolutely. So, just to give you an idea of the markers, we looked at 3 inflammatory markers, with calprotectin being the main one, but we also looked at CRP and his SED rate. And so interestingly, this is before we repeated the calprotectin level. This was 23 days in, so a little over 3 weeks. His symptom survey score, so this is the symptom survey we use with the LEAP protocol, went from 39 to 6.
Wow, nice.
His athlete's foot resolved within 23 days. And his eczema, he'd had a patch of eczema behind his ear since he was a toddler, mom said. And she said that had, was improving at that point. Okay. So let's kind of update that. So we measured calprotectin again 39 days later. Okay. And the inflammatory markers. So CRP started out at 1.6. It went from 1.6 to 0.6, which is in the normal range.
Yeah.
SED rate was initially elevated at 17. It went down to normal. It was 9. Okay. His initial calprotectin was over 2,000. So the lab didn't even measure anything over 2,000.
Yeah. Like cut off.
Yeah. So the lab normal with this lab for calprotectin was less than 163. Okay. So keep that in mind. So in 39 days, his calprotectin went from greater than 2,000 to 186.
Wow. Almost normal.
Yes, almost normal.
Cool.
Yeah. So it was kind of funny. I had been in the office Friday and seen this come over the fax, but nobody else was there that day. It was usually a day off. But so Monday morning, Dr. Strobel comes in showing me these results, and he says, "You've got a little bit more work to do."
Yeah. Tell him why you start pulling your weight.
But I also should say, let's see. I'm trying to think of the time frame. So 4 months later, his BMI increased from the 3rd to the 10th percentile. Initially when he came to us, he was below the 3rd. Well, he'd gotten it between the 3rd and 10th.
Awesome.
And so in 4 months on this restrictive diet, right, he was in the 10 to 25th percentile now, his BMI.
Cool. It's impressive. Yeah. Okay. So for that full 4 months, he was on the greens only. So the safe foods only from the tests. And then how long did you keep him on the greens after that?
Let me let me get to that here in just a few minutes.
Okay.
He was ultimately able to add back in some of his foods. He did regain oral tolerance, but I'm just going to say that mom is so pleased with results. His symptoms are improving. So,
Okay.
they're going to be a little gun shy at making a lot of changes early on.
Yeah. Yeah. If he's doing well and they're not feeling overly stressed by the diet, then maybe stay on it longer.
Yes.
Yeah.
So, just to make a comparison, and this perhaps isn't fair, we're talking about one case study compared to a group of patients in the PLEASE study. Okay.
Yeah.
Um, let's see. So they had about, I think I said 65, 66% um, improvement in the calprotectin levels.
Hmm.
And it didn't matter whether they on the drug or the exclusive enteral nutrition. So, and that was over 8 weeks. So in 6.5 weeks, this kid went from 2,000 to 186. That was a 90% decrease in his
Yeah.
calprotectin level. So it's just a pretty remarkable result.
Yeah. And then you probably are going to this, but from my recollection of reading it, it sounded like he had like a prolonged remission, right?
Yeah. So the next thing is about a year later, he was seen back in for the office, and Dr. Strobel just said, this is a remarkable remission of symptoms. Let's do a biopsy and see histologically what that's telling us, right?
Hmm.
Well, at that point, mom was very reluctant to do another procedure if your kid's feeling
Yeah.
well. So it did take a bit of time to talk her into that. But anyway, long story short, EGD, colonoscopy, 10 biopsies from mouth to anus showed no evidence of disease. And so at
Wow.
that point, his GI meds were discontinued, the Pentasa and the omeprazole.
Oh, nice.
Yeah. So that was a year after starting the MRT protocol. And at that point, he was continuing to avoid processed foods and food chemicals. He'd worked most of his foods back into his diet, but he was still limiting dairy, eggs, pork. They seem to still provoke symptoms of headache and stomach aches. So, you know, they kind of worked through that over the course of the year.
Yeah.
So that's kind of where he was at that point. Um, so about 3 or 4 months later, followed up. He was doing clinically well off all his GI meds. He was continuing his probiotics, his Curcumax Pro. Um, he did make it up to almost, well, between the 25th and 50th percentile at that visit on his BMI. Okay.
Wow. Awesome.
Yeah. So a year after that, so now we're 2 years and 3 months or 4 months out. He was still in clinical remission, normal SED rate, CRP. Not sure a calprotectin. Yes, he did a calprotectin at that. No, we didn't have one at that time. He'd lost some weight. His BMI was down to the 10 to 25th percentile, so he wasn't able to maintain the higher percentile, but he was doing reasonably well. We also did a new Crohn's disease test called Monitor Crohn's. That was the
Mm.
first serum test that was a marker for mucosal healing. Again, another surrogate marker. So we did that. So now we're over 3 years into it. And
Wow,
this is
okay.
kind of the last follow-up. I'm sorry, I'm kind of
You're
confusing.
good. You're good.
Little over 3 years, 3.25 years. Calprotectin was at 119, and his
Wow.
monitor Crohn's was at a score of 20. So anything between 0 and 40 is consistent with remission.
Cool.
So, yeah, that's that's kind of it. That's our story.
Awesome. That's so amazing. Nice work with him, Jennifer. Crushed it. Did after that, when the antifungal protocol was done, did you continue with the probiotics and the curcumin, or how did that all play out?
Yes, I'd have to go back and look. I don't
Mm,
remember how many months. Typically, I would do the antifungal for several months,
mm,
probably 3, 4 months. And it would again depend on his symptoms. And once
yeah.
he was, I would taper him off the antifungal, but he did take the probiotics and the Curcumax Pro for a very long time afterwards. Yeah.
Awesome. Well, awesome job. And then I did, in case you're here live, I did link in the chat, or if you're watching on recording, I linked to the study in the chat if anybody wants to check it out. But kudos to you, not only for the great care of him, but also just for getting that work in to publish that paper so that people can see the evidence of what you did. Um, is there anything else you want to say about his case or about LEAP MRT or anything else about his protocol?
Um, I can't think of anything.
Okay. Are
Yeah.
you, tell me how you're using MRT right now. Are you still combining it with like a gut, well, it's called a gut protocol, sort of what he had? Like, are you typically doing that still, where you'll put couple the gut protocol with the LEAP diet?
Yeah. So as you know, it's not cookie cutter. It depends on the patient, right? Of course,
Mm-hmm.
when you're doing functional therapy. But yes, there are many times that I will couple MRT with an anti-yeast protocol.
Mm-hmm.
Sometimes we tackle the yeast first, and then
Mm-hmm.
we add on the food sensitivities. It all dependent on the patient and what they're willing to do and ready to do and how sick they are. They're highly motivated when they need to get some symptom relief. So it varies.
Mm-hmm.
And typically when I couple the yeast protocol with MRT, I don't take them through the phases, especially with adults. My adult yeast protocol is a little bit more complex, more complicated.
Mm-hmm.
And I just think taking them through the phases,
Adds to that. Yeah.
yeah, and it's a little bit much for most people to
Mm.
handle. Actually, the
Yeah.
interesting thing is I had an intern who was very dietetic intern who was very interested in functional, and he wanted to do this protocol and needed to do it. So, I
Cool.
took him right through it. He's the only
Oh,
client I've ever had that wanted to do the anti-yeast and LEAP phases,
together.
and
Oh
he did
gosh.
it. He had amazing results, but, it's just a little bit
It's for a
much
special
for
person.
most people to tackle that. Yeah.
Yeah, for sure. So when let's say somebody's on an antifungal protocol and you get them an MRT test, is your LEAP diet going to be similar to what you used in this case, where you just say, hey, just only the greens?
Yes, for the first 4 to 6 weeks, and
Mhm.
so we would remove some of you know, the added sugars, of course.
Mhm.
From that, we also would remove mushrooms, peanuts, pistachios, potential mold producing
Yeah.
foods, a few things like that we would remove even if they're deemed safe.
Mhm.
Um, but, we transition as soon as we start seeing enough improvement in their symptom survey scores. I really scale back on the anti-yeast protocol.
Mhm.
I even, sometimes after even 1 month, I'll let them have small amounts of added sugar in a savory product. Let's
Okay.
say a savory salad dressing that has a gram of sugar in it.
Wild
Uh,
thing.
yeah. So, no concentrated sweets for a
Mhm.
while, right?
Yeah, for sure. Okay, so Jan put a question in the chat, and actually the same question I had, but I was kind of scared to ask you. But
Oh,
since
no.
Jan put it, I'm going to ask you. When I read your abstract, it definitely discussed the MRT, but I didn't really see mention of like the gut protocol or the turmeric or the curcumin. So it kind of made it sound like you felt like the MRT was the most important thing for helping this patient. But in our discussion, I kind of questioned that of like, Jan's question is basically like, how do you know that the MRT is actually what benefited him? How do you know it wasn't something else, like his medications or his antifungal protocol or his avoiding sugar? And like, how do you know that the MRT like did anything?
Great question. So number one, when we did the MRT, the kid was in trouble. You know, he had he was out of remission, rectal bleeding. He didn't get any more drugs. Okay. He maintained the drugs that weren't working.
Yeah. Yeah. We already saw, that's a good point. You already saw those weren't doing anything for him.
Yeah. So even though the yeast, the turmeric, whatever, may not be mentioned in the abstract, it's covered in full in the context of the article.
Yeah. Yeah. So I don't know your answer to the question, but this is an extremely common thing, the way my patients play out, where I'm often doing a very similar thing. Like you're getting a gut protocol, you're getting a LEAP diet or some other type of therapeutic diet that's aimed at lowering inflammation, and you're getting maybe some other thing too. And then they like feel like $1 million and they're like, great. And if we stick in like allopathic thinking around, like traditional healthcare is very good at finding those few very clear mechanisms where like this drug will fix this problem by this mechanism for this disease. And so it's great for those rare situations, but with integrative and functional medicine, you're considering the interconnectedness of all the systems of the body. And so you might be working on those different systems with different things, and it's hard for that type of thinker to translate to that like maybe there's no way to know what piece of the pie the curcumin is responsible for versus the antifungal protocol versus the LEAP diet. But is that the most important thing, or is the most important thing that like traditional healthcare couldn't help and like this did?
Right.
That's like the $1 million question, I guess.
Yeah. But. Right. What part of those three things, what degree did it play into it? But setting up all the research for the Crohn's disease pediatrics over the course of time, we know that diet plays a role and that there are personal food triggers, just not knowing what they are. So let's give them a formula that cuts all of those out. That works.
I get that's a really nice way to bring it back full circle to how we started off, is when you shared about, okay, we know from back in the research decades ago that on these highly anti-immune triggering formulas, kids achieve remission. So we know that there's a powerful role of like food antigens in the picture.
Absolutely.
And so you still don't have conclusive evidence, of course, that the MRT LEAP did anything here, but it would follow from like what mechanistically from those studies that it likely played a role. And maybe it's okay to not know the specific degree, like if it's measurable, because it's something that's low risk, especially because you're a professional that's monitoring him. You're monitoring his weight, his nutritional status, his tolerance, his mental health around his diet. So to me, it's safer than a Walgreens Everlywell or whatever like test is like the test of the minute. You know what I mean?
Right.
Yeah. Well, Jennifer, this was amazing. Again, super admire you for what you've done. And do you think you'll do any more?
Well, it's interesting. Since I started my private practice 4 years ago, I still do see pediatric patients, but I see a lot more adults now.
Yeah.
And I certainly do use this MRT, and if it's appropriate, antifungal therapy in inflammatory bowel disease, particularly Crohn's disease.
Yeah.
So, yes, the answer is yes.
Awesome. Well, I'm sure that people will be curious about you and want to learn more and possibly reach out. Maybe share little details about your website and how people can get in touch with you.
Well, my website is gijennifer.com. My email is jen@gijennifer.com. My website, you can get all my contact information, including my phone number. So,
Dang,
uh,
okay, you're the devil.
yeah, I'd love to collaborate
Yeah,
with anyone. I love doing this work. And thank you, Erin, for having me
of
today.
course. Oh my gosh,
Yeah,
thanks
it's
for
my
coming on.
pleasure.
It was a joy. Thank you again. And when we put this out, we'll make sure to tag you and put your details and everything so that people can find you.
Thank you.
Take care. Talk to you later.
Okay, bye-bye.